Good evening, everybody, and a warm welcome to this webinar. And we have our chief guest speaker, Dr. Anirvan Chatterjee. Dr. Anirvan is the founder and CEO of HaystackAnalytics, a leading startup in the field of genomic analytics, incubated at Science IIT Bombay. Dr. Anirvan has obtained his PhD from FMR Mumbai and has done his postdoc from University of Oxford, the UK. He's done an additional postdoc from the Technical University of Denmark. Dr. Anirvan has been involved in TB research since more than 2 decades. He has been instrumental in the uptake of the whole genome sequencing test in UK and has been part of several multi-country studies as well as multi-centric studies. He has contributed valuable data in the field of tuberculosis research as well as in genomics and has enabled several solutions in bioinformatics. So again, I welcome Dr. Anirvan Chatterjee.
To begin with, again, I think it's really a huge opportunity for us to have tied up with ThyroCare and on this. While ThyroCare needs no introduction, HaystackAnalytics does need some introduction. We are a lab company out of IIT Bombay. We work in genomics technologies, and what we really believe in is genomics should be accessible to everybody. And by that, we mean that not only the technology, but the ability to use the technology should be widely available. And that can actually change the entire way we use genomics. With my experience in tuberculosis, the first disease of choice was tuberculosis that we worked on. We have been generously supported by the Department of Biotechnology, Departments of Science and Technology, and others. So to begin with, we need to understand this entire phenomena of multi-drug resistance and what has it got to do with multi-drug therapy? Well, it has got nothing to do with multi-drug therapy because multi-drug therapy was designed so that multi-drug resistance doesn't come. Because evolution always results in drug resistance in some form or other. Because TB is a slow-growing bacteria, the chances of developing drug resistance is much higher than other bacteria. And very early on, WHO and the scientists of the world put together this idea of putting multiple drugs so that if one drug doesn't work, the other 3 kills. If the second drug doesn't work, the other 2 kill. And what happens now is, if we are now giving a multi-drug therapy where 3 drugs don't work, 2 drugs don't work, then we no longer have a multi-drug therapy. And that is at the crux of some of the problems we are facing in the world today, where when we are expecting that the patient is undergoing a multi-drug therapy, the patient might not be undergoing a multi-drug therapy if we have not tested all the drugs that we are giving to the patient. Which means, in a multi-drug therapy, when one or more drugs are not working, the other drugs are at risk because they can develop resistance much faster. So this is the standardized regimen for tuberculosis. This is very well understood. This is very well updated by WHO and other agencies of the world. And the success of this treatment in the patient is associated with the use of the selected drugs. And the greater number of effective drugs that are put in, the better is the treatment outcome. The challenge, of course, has been on the technological side. As universal DST has been rolled out, it has become more and more challenging because there is no one single method which is perfect for finding out this drug susceptibility. When we compare the molecular tools versus the phenotypic DST, we find that even phenotypic DST has sometimes much higher error rate for a few drugs than the molecular tools. And we also understand that there are some phenotypic DSTs which are really, really gold standard and cannot be probably replaced by a molecular tool. And this is a big challenge because if a patient has to undergo multiple tests to arrive at the right decision of the therapy that must be given, in a resource-limited setting like India, this becomes extremely challenging. To call a patient who is already stigmatized to a diagnostic center, to a clinic for multiple tests for the medicine, we are ensuring the patient is not going to comply with the therapy just because we are not able to provide the right therapy just because we've not been able to identify the right drugs. That technical challenge is the origin of resistance and the criteria that we use to make that choice of drug resistance and make the choice of therapy thereof. The interpretation of results and data reporting must be standardized to an extent where a country like India, where there are 30 lakh patients, they can all access decision in the best possible format at the earliest point of time. When you look at WHO and their list of drugs, there are several drugs for which phenotypic DST has been listed as not reliable and not reproducible. And this is the gold standard. The challenge remains on the technological side, on the microbiological side, that we don't have a unified test to provide a universal DST. If we don't have universal DST, we can't decide on universal regimen. If we can't decide on universal regimen, we are going to lose one drug after another and one patient after another. One of the best things that happened over the past 15 years, while genomics has changed everything from vaccines to cancer therapy, what has happened is the scientists across the world have put their head together for this neglected disease and produced significant publications, one after another. The Harvard School of Medicine, the University of Oxford, the Swiss Tropical Institute, the Johns Hopkins, they've all come together and proved time and time again that next generation sequencing is probably coming up as one solution which will have the best chance of giving us that decision very, very early on in the life of a TB patient. I have been very fortunate to be part of some of these studies with some of the key opinion leaders in this domain, and we now are looking forward to make genomics for TB as the standard of care. I'm not saying we are already there, but we have started. ThyroCare has taken that lead, and it's not just us. In 2015, the NHS rolled out TB genome sequencing. In 2017, the WHO launched the first next generation sequencing guidelines for tuberculosis. The government of India, the programmatic management of drug-resistant TB. And this is really, really critical because we're talking about India, we're talking about India's healthcare system, and we're talking about tuberculosis. We all think that we are not working in that aspect. And this year, the tuberculosis elimination program in India has already put out next generation sequencing as one of the key technologies that will be onboarded in the TB elimination program in India. As far back as 3 years back, the preparations have started with 6 sites in India already doing TB genome sequencing to understand its implications on surveillance, to understand its implication on drug resistance. Just a few days back, the WHO brought out the updated catalog for tuberculosis. Right now, we are already looking at 18 drugs that the WHO has put out, which can be used for identified drug-resistant tuberculosis using next-generation sequencing. Some of the team members at Haystack are already authors in that report, and we continue to work very, very closely with the government to ensure that all the data that we generate not only helps the patient that is coming today, but helps the patient all over the world with anything that we learn from genome sequencing for every patient that we are able to provide it for. When we talk of tuberculosis, we talk of defaulting. We talk of defaulting because people don't take drugs, people don't comply. What we fail to understand is if we don't give a therapy which works every time, the patient is not going to continue with the therapy. Globally, we know that more than 75% of MDR are untreated. Why are they untreated? They are untreated because the patient is stigmatized. They are untreated because there is a delay in diagnostics. They are untreated because the treatment is delayed. Inaccurate therapy is probably one of the most important reasons for why we have landed ourselves in this situation and why the world has come together to rectify it today. We urgently need to stop defaulting, and whole genome sequencing is probably one of the most crucial steps the world has already taken towards it. With ThyroCare, we have now launched whole genome sequencing for tuberculosis at an unbelievable cost to the patient of 3,000 rupees, which is a launch price. The values on the negative predictive value, the positive predictive value are just like any other molecular test, because whole genome sequencing is molecular to the next level. And it is now being done in a lab which is ISO accredited, NABL accredited, CAP accredited. They already do Gene Expert, LPA, LDST. And today, the whole genome sequencing is available in that same lab, which does more than 10,000 tests for the government, just that one lab. When ThyroCare provides the whole genome sequencing, it provides screening for 18 antibiotics, the newest one. And the best part about whole genome sequencing is if today when I go back and I find that there is a new mutation which is known to be associated with pretonomid, it will be available tomorrow on the catalog with ThyroCare. Today, the turnaround time is 12 days. When you compare that to a culture DST, which can take up to 60 days, it's an impossible feat that we have already achieved. And we are not stopping here. The more samples that we get, the more inspired we get by the reactions of the clinicians, the more we strive harder to create this technology. At ThyroCare, we are committed to ensure that we bring it down to a place where every TB patient in India must get a drug that works. Several clinicians know that a TB patient responds to therapy and after 3 weeks returns back because he stops responding. There are several articles which have shown that there are mixed infections. Whole genome sequencing provides us the opportunity to identify that, provides us the opportunity to identify NTM, so that an NTM patient is not given a TB therapy, is actually given an NTM therapy. That is the value of whole genome sequencing. And the value of working between ThyroCare and IIT Bombay startup is that we create technologies which work for India, create technologies which are affordable in India, and we have provided it to ThyroCare, which has integrated into their world-class laboratory. It is integrated into their CDST laboratory. The entire genomic analysis has been automated. A report that goes out from ThyroCare every day is an automated report. It cannot be changed. It is the best-in-class report that one can offer. The interpretation is already there. The reporting itself, we have worked so hard so that every doctor who has ever used a molecular report knows that when we put out rifampicin mutation not detected, it means that rifampicin will work. For doctors who want an even quicker identification with large number of TB patients, that they say there's an antibiogram which clearly states that these are the drugs which are in the red and cannot be used for that patient. You must choose drugs from the green, which works best for the patient with the least amount of side effects that is possible. This is the kind of report we want clinicians to use today for treating their whole genome, for treating their tuberculosis patients. We don't want the clinician to worry whether it's a mutation or a variant or a polymorphism. We just want the doctor to understand that these are the drugs based on the WHO list that works. When we do the whole genome sequencing of a patient today, we detect the drug resistant for that patient. We diagnose the patient with the right kind of tuberculosis that the patient has, but we also discover the new mutation. Large number of mutations which we keep on analyzing at the back end provides us the ability to suggest the system to that we have found a mutation in a patient which seems to be in a drug-resistant clade, which means we don't have to wait for 6 years for a clinical study to come out and tell us that there is a new mutation which goes for drug resistance. For every patient that we treat on whole genome sequencing, the patient itself is providing tremendous value for the next patient that comes in with the new mutation that we detect. So where can you clinicians start using it? If I were asked, whole genome sequencing should be done for every patient, but I understand very well. I've worked that this is not possible. I've worked in the slums of Dharavi. I've worked in several rural locations. I know it is not possible. I know despite all our efforts, it's still not accessible to a large population. But at least every TB patient which is rifampicin resistant on Gene Expert, can't we get them into a whole genome sequencing test? Isn't that worth the gamble that we want to take so that after 12 days, we have the report from 18 antibiotics and the clinician is now empowered to give the patient the right drug at the right time? We think all presumptive MDR cases, all retreatment cases, all relapse cases must undergo whole genome sequencing as a screening test before the doctor takes the plunge in. This is probably our best chance at stopping the rise in XTR and stopping the rise in XXTR. Because we must remember, we have an excellent TB program in this country. What that means is a TB patient today in India is getting the best treatment, which also means every drug susceptible case of TB in India will be relieved from that situation and will not transmit. That means the only people who will transmit are the patients who do not get the right drugs. We don't want to replace a treatable epidemic with a very, very difficult epidemic. And today, the idea is to provide universal DST at the earliest possible time. And ThyroCare has taken this lead to provide this test at a price which is almost comparable to the price of a LPA per plus a gene expert done together.